We have with us NNF National President Dr. SUSHMA NANGIA ma'am, Dr. Satish Luja sir, Dr. L.K. Bharti, Dr. Jaleel Ahmed, and Dr. Pankaj Garg. I request Dr. Pankaj Garg to please introduce the chairpersons for the day and the speaker.
Welcome all
Dr.
the
Pankaj?
delegates of this eNeo course, which is specifically designed for office-based pediatricians. This is the penultimate course. This is 14th session in progress today, and we have 15 sessions in total. So next session is on 11th, and after that we plan to post you a MCQ-based questionnaire, which you will be expected to answer within 24 hours of posting. And depending on that, we'll be issuing e-certificate. We have been saying that in our chats for last few sessions. So coming back to today's session, which is a very important topic. So from the neonatology, which is dealt in office, we are gradually shifting in these last two topics to something which many of us office-based pediatricians also do in little bit of neonatal respiratory disorders. So topic for today is respiratory distress in newborns. And to do that, we have a very, very important personnel, the president of National Neonatology Forum, Dr. SUSHMA NANGIA. She's the professor of neonatology department at Lady Hardinge Medical College, and she has been the DM teacher for the DM courses on neonatology at that institution for many years now. And the chairperson for today's session is Dr. Satish Saluja. Dr. Satish Saluja is my boss, chairman of Department of Neonatology, Sir Gangaram Hospital. We have been working together for close to 30 years now. He is a very great academician, and his questions always interview you whenever he asks something which is very, very interesting and at the same time difficult to answer. He has been the NNF Delhi president. He has been Central NNF secretary, and he has held many important positions in his career. So I request Dr. Satish Saluja to say a few words about respiratory distress in newborn, and then we hand over to Dr. SUSHMA.
Good morning, all of you, all the panelists and the attendees, participants for this important webinar, where we have Dr. SUSHMA NANGIA, a well-known neonatologist, who is currently the president of our National Neonatology Forum. She has been the head of the Department of Neonatology at Lady Hardinge Medical College. And above all, she's a dear friend. I still remember those early years when we were relatively younger. We used to travel together for many workshops we conducted for facility-based newborn care, NRP programs. And she's going to speak on a very important topic. She's a great researcher. She has a large number of national and international publications, and she has landmark work on meconium aspiration syndrome, babies prevention, endotracheal suctioning of vigorous versus non-vigorous, and she's very keen on aggressive enteral nutrition. And I'm sure when we talk about RDS, we don't talk about RDS management in isolation. We talk about various other modalities of treatment to improve outcomes in neonates who have RDS. I'll not take much time, and I'll request Dr. SUSHMA NANGIA to take over.
Just before we begin, we welcome Dr. Jaleel Ahmed, Central IPB member from Tamil Nadu. He is eminent neonatologist at Coimbatore. And we also welcome Dr. L.K. Bharti, former Secretary and Vice President NNF and President NNF Delhi. Request Dr. SUSHMA NANGIA ma'am to please start sharing your screen.
So good morning, everyone. And it's a good initiative, I would say, Dr. Pankaj and team, Dr. Ajay, all of you, that you engage people right on Sunday morning for academic session. And I see a gathering which is quite good. So I'm attending it. I mean, I am attending it for the first time. I haven't attended any of the earlier ones. As you said, you had 10 of them, or this is the 11th one I heard.
This is 14th. This is 14th.
Okay, sorry.
Yeah.
So this is the 14th one. So good initiative, I would say.
We'll
Thank you. Yeah. Thank you, Dr. Saluja, for being there. And So I have actually no worries because Dr. Saluja, if he is there, so questions can be taken up by Dr. Saluja. I can just do the monologue of speaking out. We have a very important topic at hand, which is respiratory distress in newborn. It is probably, why probably? It is the commonest reason for a newborn to get admitted in the NICU. And whenever you see a cross-section of babies in the NICU, walk into any NICU, majority would be babies who are receiving respiratory support. So let's look at why babies have respiratory distress and what do we need to do for managing them. So I'll just share my screen. Okay. Is the screen visible?
Yes, ma'am.
Yeah.
Ma'am, please make it full screen. It's visible.
Yeah, I've done that. It takes a while to get on.
Yeah, it's fine now.
Thank you.
All right. So we're going to talk about respiratory distress in neonate, and I understand this is for office practice. So we're going to discuss how we manage babies who have respiratory distress. So let's look at one baby who's a 30-weeker male baby delivered by spontaneous vaginal delivery and a birth weight of somewhere around 1250, 1265 grams. Baby cried immediately after birth, did not require any resuscitation, so to say. Apgars were 7 and 8 at 1 and 5 minutes. And by 5 minutes of life, within the delivery room, baby is noticed to have respiratory rate of 70 per minute and with intercostal and subcostal retraction. Sorry for this spelling mistake. 70 per minute. So is this baby in respiratory distress? I'm not sure if we can have any responses, but if we do have responses, it will be good, which could be in the chat or I don't know, how do you run these sessions, Dr. Pankaj?
Ma'am, they post queries in the question answer session box and we keep on answering them and some questions in the end. So I request Dr. Saluja to please keep on answering the questions in the question answer box.
Okay.
Right. So this baby is the baby in respiratory distress? Yes, this baby is in respiratory distress. And why do we say that? We say that because, sorry, it's not moving. I have an issue. All right. So we say that because the baby's respiratory rate is more than 60 per minute, and I put a star there just to remind that we need to count the respiratory rate for 1 full minute rather than counting it for 15 seconds multiplying by 4 or 30 seconds multiplying by 2. It must be, and you all know that babies do not breathe at a consistent rate. They have rates which go higher up and then they come down. So it's important that we count it for 1 full minute. Retractions, if they are present, this would be respiratory distress. If there's a grunt, cyanosis may or may not be present, and tachypnea can be because of reasons that's other than respiratory causes. However, if the baby is apneic or gasping, we need to resuscitate the baby immediately. So since this baby had a rate which was more than 70, had retractions in the labor room itself, this baby does have respiratory distress. So how do we assess the severity? Is this severe? Is this mild? How do we assess that? So we have 1 or 2 tools at our hand. First, I would take you through the Downey score, wherein we look at the respiratory rate, whether baby has cyanosis or not in room air or with oxygen as well. Is the baby grunting? Are there retractions present? And how is the air entry, whether it is bilaterally equal, fine, or it's diminished, or we are barely able to hear it. And so you have the scores of 0, 1, 2 for each of these 5 items. And the baby could have a score of 0, which means he's fine, no distress, and could have a score of 10 as well. So anything between 0 to 10. So this is a score which can be used both for preterm babies as well as term babies. And it's been found to have, whenever it was studied, less inter-observer variability. A score of 7 or more would indicate severe respiratory distress. A score of 4 to 6 would indicate that the baby is in moderate respiratory distress, and anything which is 1 to 3 indicates mild respiratory distress. We can look at that as to why do we need to categorize them in severe, mild, or moderate. One is to initiate the respiratory support, and 2 would be to eventually monitor the baby He came in with moderate distress. With your therapy, the baby is now having a score which is reducing from 5 to, let's say, 4, 4 to 3, and you know the baby is improving or responding to your therapy. The other one, which is specifically for preterm babies, is Silverman-Anderson score, which has, again, 5 components, each being scored from 0 to 2. And this does not have respiratory distress, but what it has is upper chest. How is the upper chest behaving? How is the lower, vis-a-vis the lower chest? Is the upper chest synchronized? When the baby is breathing in, upper chest goes up along with lower chest, or there is some lag while inspiration, or there is a completely seesaw movement. Lower chest retraction, no retractions, just visible marked. Xiphi sternum, similarly, you're looking at the retractions. Nasal flaring, there is no nasal flaring, minimal and marked. And expiratory grunt, none audible, audible with a stethoscope, and even audible without a stethoscope. So that would be what we are looking at in terms of the score. Again, this is how it is marked. And a score of 7 or more would indicate severe. It's similar way, 4 to 6 and 1 to 3. So this baby had Silverman-Anderson score of 3 by 10 in the delivery room. What should be our immediate action? So we have nothing in the chat. Okay. So what would be our immediate action? Our immediate action would be to initiate this baby on CPAP in the delivery room itself using a T-piece resuscitator. And what would be our initial CPAP settings? Well, our initial CPAP settings, the initial pressure could be 5 centimeter water, and oxygen concentration you would titrate as per the is there
इसका पीडी फर्स्ट ईयर कह रहा है 40 फाइलें बनानी है जो नए पेशेंट एडमिट होंगे आप आ जाओ हॉस्पिटल आ
I can hear some sounds in the background. Could the chairperson request the participants and others to be on mute? So the CPAP delivery would be 5 centimeter water, and oxygen concentration we need to titrate as per the target oxygen saturation or the minute specific saturation therein. So as per the CPG guidelines, NNF CPG guidelines on WHO care of, as well as the WHO care of preterm neonates. So starting target 5 centimeter water. This is a strong recommendation based on NNF CPG, but this is based on moderate evidence. So need to start at 5 and target saturation minute specific. So 2, 3, 4, 5 minutes, and you see what the target saturations are. And we need to adjust the FiO2 in increments of 1, or also if required decrements of 1 per 30 seconds. And this is as per the WHO care of preterm babies, the target oxygen saturations. So this baby was started on delivery room CPAP at a pressure of 5 centimeter water with requiring an FiO2 of 0.3 to maintain the saturation, as we saw in the previous box. And he was shifted to NICU for further care. Labor room shifting out temperature was 36.6 degrees Celsius. Silverman score was 3 by 8. The baby did not have any shock, so he was hemodynamically stable. So does this baby require surfactant? What do we feel? The baby's scenario further, by 60 minutes of life, he had to be optimized to a CPAP pressure of 6 and required FiO2 of 0.35, saturations being maintained at 92%, admission temperature 36.2, from the labor room exit temperature of 36.6. This is an important thing to be monitored because hypothermia itself can aggravate the respiratory distress. So we need to keep a tab on the temperatures, and we need to, of course, maintain them in the normal range. So here the baby's temperature was, he was in cold stress when he arrived at the, when he was at the unit. Silverman score was 4 by 8. Of course, no shock. So does this baby require surfactant? Our question remains. And so let's see what are the indications of surfactant in a preterm neonate who has respiratory distress at birth. So as per the NNF CPG guidelines, the group on surfactant, early ensure therapy should be done within 2 hours. It's a weak recommendation. RDS stabilized on CPAP who need pressure more than or equal to 6 centimeter water and FiO2 0.3 or more to maintain saturations equal to or more than 91%. So this is what is the NNF CPG recommendation. So based on that, the baby requires surfactant. So can Lisa be preferred over Ensure? Yes, there is weak evidence to say, but we need to look at resources available and the feasibility of implementation of the same. This again is as per NNF CPG guidelines. And what's very clear is that LMA, laryngeal mask airway, not be used for surfactant installation because it cannot be used in babies less than 34 weeks. Size 1 is actually meant for babies 2 kilos or more, which is around 34 weeks or more. So we could use Ensure or we could use Lisa, but LMA, as you just saw, is not recommended. So surfactant, which preparations do we have? We have now quite a few preparations. Earlier on, when Dr. Saluja and I probably started using surfactant, we only had Survanta available to us. This is a Biractant, dose of 100 mils per kg or 100 milligram per kg or 4 ml per kg. Biractant, 50 milligram per kg or Poractant. So Poractant has been shown to have some survival advantage when it is used in a dose of 200 mg per kg compared to 100 mg per kg of Poractant or compared to Biractants. So that's what we have available as Curosur, 100 to 200 milligram per kg in the doses of 1.2 to 2.5 ml per kg to be instilled. So as per NNF CPG guidelines, Poractant is preferred, but this is again weak evidence to say what is preferred in the dose of 200 mg per kg, not in dose of 100. So there would be questions, do we need any adjuvants with surfactant? So early intratracheal steroids, as have been studied in some of the trials, may not be used. Again, evidence, there's not much, so it's a weak evidence, but it's clearly on the side of saying may not be used along with surfactant, so only surfactant installation. Beyond 34 weeks, can we use surfactant? Well, it can be used. Early surfactant may be used, not even can, may be used in late preterm and early term with RDS who satisfy the criteria for surfactant therapy. And please notice the criteria for these bigger babies is an FiO2 of 40% with a PEEP of 7 centimeters. Again, it's a weak recommendation, but this is what is the recommendation if we need to use it in bigger babies. So obviously, you're optimizing them on CPAP, and if they end up requiring this kind of a setting, they may be candidates for surfactant. Beyond RDS, so since we are talking of surfactant, so beyond RDS, the only two other conditions is severe bacterial pneumonia. One second. Severe bacterial pneumonia. Sorry. So beyond RDS would be severe bacterial pneumonia who need invasive ventilation with an OI of 15 or late preterm term neonates with severe mass, again needing ventilation with an OI of more than 15. So these are the non-RDS recommendation that should be considered for surfactant. So moving on, the neonate was administered surfactant. So now does this baby also require caffeine? So for caffeine, 3 usual indications. We have the dose, etc., which of course is available in standard guidelines. So early prophylactic for babies less than 30 weeks who are on respiratory support. Less than 30 weeks on respiratory support, yes, early prophylactic could be started right from day 1. And we need to stop at least 7 days when after the baby is off respiratory support. Peri-extubation used for 48 hours, started 24 hours before planned extubation, and therapeutic at the onset of apnea and needs to be continued till 34 weeks PMA when the baby has been apnea-free for more than 7 days. This neonate, of course, was not administered caffeine. So at 2 hours of life, distress is 2/8. Baby has been hemodynamically stable from the beginning. Should we initiate antibiotics in this baby in view of respiratory distress? Well, we need some more information before even deciding to investigate for sepsis, leave alone treat. So we need some antenatal history pointers, look at the perinatal history. We also need to run through differentials of RD in a preterm neonate because we are dealing with a preterm baby here. And of course, complete examination in a quiet state and ensure that the baby is not hypothermic. So causes could be pulmonary or extrapulmonary for RD in a preterm baby. So for looking at the pulmonary ones, you could have upper airway obstruction in the form of coronal atresia, Pierre-Robin sequence, or laryngeal pathology. This would be visible to the naked eye here, Pierre-Robin. And lower airway could be, or even parenchyma could be delayed adaptation. It could actually be RDS. It could be a congenital pneumonia. There could be air leak. And there could be like an aspiration. We'll look at which is most tenable in this baby. Extrapulmonary causes, you could have a congenital heart disease because of which the baby may have tachypnea. Most often they would have tachypnea and very little or no retractions. Could be neuromuscular disease. It could be intracranial pathology, birth trauma, but you would have history for that. Could be shock. You would have hemodynamic instability being, assessed by you. Could be anemia if there is blood loss during the process of delivery. It could be hypothermia, as I mentioned earlier. Also, hypothermia can aggravate distress. Metabolic acidosis because of infection, hypothermia, shock. Congenital heart disease we just spoke about. It could be polycythemia. You could have a SGA baby, or it could be hypoglycemia, again, suspecting it in extreme preterm in babies who are growth restricted. So you would have a scenario to go with that when you are looking at causes which are other than respiratory cause. So since we are looking at gestation in preterm baby, we would want to know mother has received antenatal steroids or not, and this baby is RDS. We need to think of other things. If there is oligohydramnios, maybe it's pulmonary hypoplasia. If poly, it could be diaphragmatic hernia or TEF, any of these surgical conditions. You're looking at whether the mother had leaking per vaginum, she has choriamnitis. So if these are the situations, you might entertain that this could be a baby who is having infection, early onset sepsis, pneumonia. And other things, baby is not vigorous at birth, has required resuscitation. So could be asphyxial lung disease. You may even be dealing with air leak syndrome. So it depends on the overall scenario. So you need to know antenatal, perinatal events that have occurred to be able to pinpoint what could be the cause. Of course, thorough, complete examination is a must. And when you need to examine, of course, vitals, what's the temperature? Temperature can never be, emphasized enough. Respiratory rate, because I've seen babies on ventilator and whose temperatures are haywire. So obviously that baby is not going to make it or not going to improve unless his basic things are taken care. So temperature, respiratory rate, heart rate, saturation, these needs to be examined. And again, we'll see that they are the ones that need to be monitored. Signs of respiratory distress based on these signs and on objective scoring, whichever score you use. And in the respiratory system, you are looking at any additional sounds, air entry, chest wall movement. So also in CVS, you just want to be clear, are we dealing with something which is cardiac? Is there a murmur that could be heard? Is there dextrocardia, abdomen, scaphoid abdomen? Are we dealing with possibly diaphragmatic hernia? Is there hepatomegaly? Are we dealing with something which is cardiac in origin? And look at the umbilical cord, nails. Are they meconium stained in a baby who is brought from outside? You don't have a clear history of meconium staining, but when you examine the baby, these are the things that are seen. And this baby is requiring respiratory support. He's requiring ventilation. You would think of how to manage this baby. Tone, reflexes. If these are there, are we dealing with a baby who has who's suffered asphyxia or is a baby with CNS infection? So these examinations are important. So let's look at our baby. Mother had received 3 doses of dexamethasone and there was no maternal history or any risk factor for sepsis in this neonate. So the baby was not initiated on any antibiotics. So possible EONS risk factors that we are looking at is preterm low birth weight is a risk factor, but that's not something that if it's a preterm baby, we need to give antibiotics. Clinical choreo, prolonged rupture of membranes, prolonged labor, foul smelling like a single unclean or 3 or more sterile per vaginal examination. So these would be the situations where you would think of working up for sepsis, of course, not starting with antibiotics right up here, working up for sepsis, sepsis screen, combine. These are a combination of certain laboratory parameters. I'm sure you would have a session on sepsis, so I'm not getting into the details of that. Suffice to say that we need to work up the baby if we feel that there are risk factors, significant risk factors for sepsis. So in this baby, 30-weeker, we at 2 hours still on CPAP, 5 centimeter, FiO2 is down to 0.25, hemodynamically stable from the beginning. When should we start feeds in this baby? I wish we could have some poll. So do we start him now at 2 hours? Do we wait for 6 hours, or do we wait till his distress settles and he is off CPAP, his score is 0, or wait till, wait till he's off support? So what should we look at? What should we say? I made a mistake. I have opened this. It's not. So when should we start feeds? I don't think I have any responses. I was trying to look at the responses. So, well, we don't have to wait till this baby has been hemodynamically stable from the beginning. He has been able to maintain his saturation on the support that is required. So he is neither hypoxic, nor does he have signs of shock. So this baby's gut is functioning fine, would function fine. And we could, or rather, we should start him on feeds. What we did in this case was, we started the baby on full enteral feeds, which is his requirement for day 1, 80 ml per kg. And as you had seen, this is a 1265 grammer. For the sake of ease, this comes to some 102, 101 point something, 100 ml is his requirement for today in terms of the total fluid he requires. Can we give this total fluid his requirement as feeds? So you need to give 2 hourly feeds, which means 12 feeds in 24 hours. So divide 100 by 12, we get something like 8 ml, 12 8s are 96, 4 more ml remaining. So 4 feeds of 9 ml towards the later part of the day, and start with 8 ml feeds from now, from 2 hours of life. So the baby his fluid requirement is sorted. He is on enteral feeds. There are no IV cannula. The baby does not require any antibiotics. So the baby's skin is intact from head to toe. How should we monitor the distress in this baby? So we could do clinical monitoring. We've already looked at the objective scores, but we need to monitor them every 2 hours. If the baby settles, maybe every 4 hours, every 6 hours, but there has to be some objective monitoring, which is guiding whether we need to escalate support or whether we need to decrease support. So it's very important that we monitor. It should not be subjective. The baby looks better. His distress looks better. It shouldn't be like that. Non-invasive pulse oximetry, of course, we have. Overall systemic examination, we have dealt with that as to all the systems you need to look at. And holistic management has to continue. This is a preterm baby. So he needs developmentally supportive care with a nest around, with dim lights, with no noise, possibly no noise or very low sound in the NICU. And the mother should be called in. This is a vaginal birth. The mother should be there by whatever, 6 hours of life, 8 hours of life, right on day 1. And the mother should start doing kangaroo mother care. The nurses in the unit should help support and put the baby in kangaroo mother care position, and the mother should be encouraged to be there. This will help her express milk. This will help her have more milk output. So it has to be holistic management. We are not just talking about the respiratory part, that this is how it should be. So we are looking at the infection, we are looking at temperature management, we are looking at his nutrition, and we are also looking at developmentally supportive care, so that when we discharge this baby, or in the long-term outcome, the baby is a useful, productive citizen of the country. How do you monitor pulse oximetry? I'm sure people know, but what people tend to not focus on is alarm setting. So please, in your units, have all the monitors set with alarm settings, both for heart rate and for saturation. You can see the SpO2 saturation to be set, and we are targeting 91 to 95. So we are setting saturation alarm limits. They could be 90 and 96. They could even be 89 and 97 if you don't want the alarms to bother you very much. But it should not be that we have no alarm settings that has been put up. Pulse oximetry, I'm not sure, Pankaj, if you have, many sessions on equipment. So I just tried to put this slide over here. So there may be troubleshooting with pulse oximetry. So if there is ambient light, which is too bright, like a studio, excessive light is falling on the sensor, we need to relocate and maybe cover with a patch. Better would be that we have our NICU lights not that bright. Check sensor if there is motion, movement, or perfusion which is low or positioning of the photo emitter and photo detector not opposite each other, but they are not aligned. So we need to reposition, relocate. Erratic signals, we need to check if there is any electromagnetic waves in the vicinity, like maybe a mobile phone close by or a television which has been put up for maternal education and stuff. Low battery, of course, you need to connect to power. Sensor failure could occur because of faulty photodiode or a sensor that has been damaged. So we need to censor that. We need to change that. And if there is internal component failed, if there is, alarm is like system failure, this could have happened. We need the service in charge to come in. But for many of the others, we don't need to call the service in charge. If we know what the alarm says, what could be the possible cause, we could take corrective action on that. And this is like a fifth vital parameter. So I think all of us should know how to monitor the baby using pulse oximetry. And it's so very important that we ensure alarm limits are set and we ensure that our saturations on supplemental oxygen or supplemental respiratory therapy are maintained, because you are all aware that high oxygen concentration not only affect the eye, causing retinopathy of prematurity, they affect the lungs, causing sowing the seeds for bronchopulmonary dysplasia. They affect the abdomen, necrotizing enterocolitis. So two things that are bad for the gut is keeping the baby NPO, necrotizing enterocolitis ke liye, if the baby has too much high oxygen. So these are the things which are affecting. Brain, PVL could occur in a preterm baby. He may not have had IVH, but he could have PVL. And it's because that we haven't monitored our oxygen. So please be aware that oxygen can cause a lot of problems, not just eye, many other organs. So secondary onset of respiratory distress, we need to prevent iatrogenic complications, late onset sepsis, delayed introduction of enteral feeds and prolonged IV fluids, cold gases going through CPAP. We need to monitor the flow and pressure to avoid iatrogenic pneumothorax. So at birth, we have looked at respiratory distress. It can occur after a period of normalcy, and that would be late onset sepsis, pneumonia. And you could have many causes of them. Important ones are initial antibiotic usage, keeping the baby NPO, delaying enteral feeds, keeping the baby on IV fluids for a long time. So in preterm, we've looked at RDS. These could lead to congenital pneumonia as well. Possible causes for later acquired pneumonia, CHD, a duct which is opening in a preterm baby, could be inborn under metabolism when you've started feeding the baby. Now it manifests as respiratory distress later, or metabolic cause due to metabolic acidosis, which could again be due to infection, hypoperfusion, some of them. So let's look at CPAP, which is our cornerstone of managing babies with respiratory distress. So we are all aware that we have these components. There is a blender which is there, and you have oxygen and air being supplied into this, which is mixing it up, and you have a knob by which you can set your FiO2 from 21% to close to 100%. You need heated humidification. So heated humidified gases which flow in from the blender needs to be heated and humidified, and then only they go to the baby. So this is the inspiratory line. You could have a pressure which would monitor here, and this is your expiratory limb going into the underwater seal which has sterile water, and you should be able to see the bubbling there. So interfaces, we have nasal prongs, which could be single, binasal short prongs. So with all the evidence that has accumulated, we are very clear that binasal short prongs, whether they are of any make that you see here, are better than a single nasal prong or better than as a nasopharyngeal prong. Nasal masks, of course, have come in. So short binasal prongs vis-a-vis nasal masks would be the ones that could be used. So what you see here are the different CPAP interfaces, short binasal prongs from Hudson. This is Ram's cannula. This is nasopharyngeal prongs, which were long going into the nasopharynx, which nobody, I think almost nobody uses. This is the nasal mask. You have short binasal prongs from another Argyle and from some other company. And we have this slide, which has been prepared by our ex-president, Dr. Praveen Kumar. We continue to use it because it shows them all together in one slide. So getting started, we are all clear. 5 centimeter could even be higher as per the unit policy, but definitely 5. Do not start with a CPAP pressure of anything less than 5. Don't start with 4 and then go up. We are wasting time at that point. So start with 5. Some of the units would have starting pressure of 6. With FiO2 of 0.4 to 0.5, there are units which would start with lower. We would not start with 0.4. We would start with 0.3. But so starting point, the whole idea is that you are monitoring the baby and you are monitoring what is the saturation that you are getting. So if you have respiratory distress or retraction still there, you could increase pressure in steps of 1 centimeter water every about 15-20 minutes to reach a maximum of 8 centimeter water of pressure. If you're not getting saturations within the target range of 91 to 95, you could increase FiO2 in steps of 0.05. That means going from 35 to 40, 40 to 45, and so on, to reach a maximum of something like 0.6 to 0.7, 60%, 70% FiO2. Pressure of 5 is traditionally used. Some, as I said, would want to, start from 4, but I would not suggest starting at 4, because by the time you move from 4 to 5, you've wasted some time, and some more alveoli have actually become atelectic. Others may use, so increasing up to 8 centimeter water. Some people might not go beyond 6 in terms of increasing, but up to 8 centimeter water, it can be increased. While you are increasing, you need to be clear and you need to be watchful for any air leaks that might occur. Apnea of prematurity would require something like 4 to 5 centimeter water and FiO2 to be titrated. Post-extubation, again, about 5 to 6. And severe RDS, whiteout lungs, we can consider even higher pressure going up to 8 centimeters. Starting pressure of 6 and going up to 8 in increments of 1. And FiO2, as we saw in the previous slide, can go up to 0.6 up to 0.7. So when do you call CPAP failure? And I must say here that CPAP failure is diagnosed more often than it actually occurs. So we don't give enough pressure, enough oxygen. We don't give us time. We want to take the baby onto the ventilator. Most of the time, CPAP failure, as I said, is diagnosed when it's actually not there. So what is CPAP failure? So even on a CPAP pressure of 7 to 8 centimeter water with an FiO2 of 0.6 to 0.8, if the neonate has excessive work of breathing, PaCO2, if you've done a gas and PaCO2 is accumulating, going beyond 60, and we are not looking at 40s here. We're looking at CO2, which is going above 60, pH, which is less than 7, or a PaO2, which is less than 50. So these would tell you that at such high settings, if you're not able to manage, maintain these, then probably. And of course, if the baby is not having the respiratory drive, he's having recurrent apnea, more than 2 episodes per hour over an observation period of about 4 hours, then that baby, and he is repeatedly requiring some stimulation. But if he requires even one time during these apneas, requires bag and mask ventilation for him to start breathing again, of course, that would be a situation that on CPAP, the baby is having apnea, which requires bag and mask, and we need to support the baby with higher modality, NIV. And of course, this talk is not going into NIV or ventilation. So suffice to say that if you diagnose CPAP failure, which is diagnosed on these objective parameters, sure, you need to move to the next, which is non-invasive ventilation. that needs to be started. So we need to monitor the baby. We need to look at the baby and the airway. So is the baby doing fine? Is the baby comfortably sleeping? Is the baby having retractions? Is the baby agitated? So look at the baby. Look at the prongs at least each shift when you take them out and see if there is any crusting in the nostril, if the prongs have got clogged, what is happening. Circuit, is there any condensation? Is there any leak? If you don't get bubbling, we'll look at that slide in a minute. And look at the machine, the FiO2. It's a good idea to check FiO2 once in a while. You may have set it at 30, 35 for this baby, but in between, if you check with the FiO2 monitor to be sure that your blender for this machine is working fine. Look at the bubbling chamber, and we need to be watchful for the complications. So the nursing care on CPAP is very, very important. More often, we say CPAP is not working, whereas we're not providing adequate nursing care. So we need to educate our nurses, train them to take care of the baby. So oral nasal suction, saline nebulization if required. So if it is prolonged, there is crusting, all this is happening then. Secretions need to be cleared. Moisten the nares with saline. As I said, when you remove the nares, the prongs, to see how the nares are. If there is drying, crusting, they need to be moistened. And with saline or with sterile water, watch for apneas occurring, any tachypnea, retraction. So worsening distress, watch for bradycardia. You need to frequently change position of the baby, not frequently enough that you're doing it every 2 hours, 4 hours, but at least once in 6 hours, 6 to 8 hours, the baby's position should be changed. Orogastric tube should be put in the abdomen to decompress the abdomen, put in the stomach to decompress the abdomen, as well as to feed the babies on CPAP. Our causes of failure really revolve around there is recurrent apnea, the disease is actually worsening, or there is additional things like baby has an intracranial bleed, or the baby has metabolic acidosis, as we said earlier, because of infection, because of hypothermia, because of other situations. There's pulmonary edema, nutrition. We're not feeding this baby, keeping NPO. Improper fixation, frequent dislodgement of the interface, secretions which are obstructing the airway and nobody is doing the nursing care, nobody is looking at that. Inadequate flow from the machine, faulty machine which is delivering lower pressure. So all this, when a baby is on CPAP, you need to look at the baby, you need to look at the machine, and you need to look at the tubings as well as the interface. How do we wean from CPAP? If the baby is stable on CPAP for about 24 hours, first wean off the FiO2, bring it, if it was higher, bring it down to up to 0.3 or 30% in steps of 5%, and then wean the pressure down to 5 centimeter water in steps of 1 centimeter each time. So in troubleshooting for bubble CPAP, you could have a baby with similar to ventilated baby, you could have dope, where the prongs are displaced or distorted, nares are obstructed, there is pneumothorax which has occurred, or the equipment is not functioning fine. We were talking about bubbling. So why it won't bubble? Complete or partial circuit leak. Somewhere there is a leak that is happening. Complete or partial prong which are disconnected, displaced prongs, inadequate flow through the circuit. So we need to look at right from the flow meter on through the circuits, the humidifier up to the baby, and up to the chamber where there is underwater, the water that is bubbling. So prongs are too small for this baby. So there's a large leak around, or the baby's mouth is open, which often by assessing the, adjusting the flow and the, so this you don't really need to close the baby's mouth. That would be a situation which is quite rare. So you could increase the flow and still bubbling would occur and the baby is receiving enough flow. So we don't need a baby who is agitated, irritated, crying. So minimal handling is the rule, not just for a baby, this is for any preterm baby. Careful interface application here, effective airway clearance, we talked about that, clustering of care, feeding and hands off. So you are only approaching the baby when the care has to be given, which is clustered care. We are not talking about an emergent situation where there's something happened, you need to take care, but you need to plan all the activities related to feeding, diaper change, the nasal prongs to be removed and nasal nares to be checked. All this needs to be planned, and it's to be done at one go. Disturb the baby once, and then you are away from the baby. So most common cause of NICU, most common cause of admission in the NICU, majority of preterm neonates would stabilize on non-invasive respiratory support. CPAP is not a contraindication for enteral feeds or for KMC. We can provide KMC very well, and the babies are quite comfortable on CPAP being provided KMC. And of course, enteral feeds, I have already talked about that. Monitor oxygen saturations closely, ensure effective and optimal humidification. This is very important. Otherwise, there'll be nasal crusting and there'll be secretions which might become thicker, and you will say, oh, we failed on CPAP. So let's look at one more case, which is a 38-weeker, presents at 2 hours of life to your unit, history of meconium stained liquor and delayed cry at birth. I'm sure we get such babies quite often, in addition to the preterm that we just discussed. So the baby is shifted on oxygen by nasal prongs. So we need to look at, sorry. So we need to again have detailed antenatal history, thorough examinations, some of the causes which are commoner in term neonates compared to preterm, and supplemental oxygen may suffice for hypoxia instead of CPAP, especially if the distress is between 1 to 3. When we did the Downey scoring, and the score was somewhere 1 to 3, so that those can be taken care with supplementary oxygen. They may not require CPAP. So pulmonary causes, especially for term, what we are looking at is meconium aspiration syndrome, congenital pneumonia, air leak syndrome, or you could even have a delayed adaptation or TTN with meconium staining. So this baby may not be actually having mass. He may be having meconium staining of liquor, which we have in the history, and he may be presenting with delayed adaptation with what we call in term babies as transient tachypnea. Extrapulmonary, of course, you have heart disease, polycythemia. More or less, the whole table that we saw with the preterm can also be contributing to extrapulmonary causes in term baby. So at birth in term baby, transient tachypnea, meconium aspiration, congenital pneumonia, or some developmental anomalies can give rise to respiratory distress at birth. Later on could be possibly acquired pneumonia right from the unit itself, where the baby is admitted for a prolonged duration. So CHD, a duct which is opening, it's not a possibility as much in preterm babies. As much in term babies, I'm sorry. So this is not a possibility in term babies. This is surely a definite possibility in preterm babies. IEM can occur in both preterm and term babies. So examination, much the same as we discussed, that needs to be assessed. And in examination, again, heart, abdomen, umbilical cord, as you can see, stained over here, and CNS examination. You need to examine the baby. You need to look for oxygen saturation, collapse or air leaks, or cardiomegaly on X-ray. And I would reiterate here that X-ray chest is not mandatory for managing a preterm baby. Whenever in the course of time you get a preterm baby with respiratory distress, whenever you get time, you could order an X-ray, but that's not what is deciding your line of management. Sepsis screen only if risk factors are present or you have clinical signs and symptoms which are suggestive. And to know the causative agent, when you're working up for sepsis, you will need to send the blood culture as well. So supplementary oxygen delivery systems, nasal cannula, as you can see here, baby is quite comfortable. Here you do not need to have the cannula size, which is, almost filling up the whole nair. Here you need to have something which may not be as snugly fitting. So preferred modes of giving oxygen to neonates, especially the bigger ones, flow could be 0.5 to 1 liter per minute, maximum 2 liters. Beyond that, the baby is going to be agitated. No humidification is required for flows which are less than 2 liters. Basically, the baby's own, the pharyngeal mechanism and up to the airway can take care of humidification. Oxygen concentration delivery by nasal cannula depends on the flow rate. weight of the neonate, and respiratory rate of the neonate. So more or less, this is what is the table that we are referring to when we are talking about the oxygen saturation that is being delivered with the flow of. So clinical monitoring needs to be done using objective scoring. In term babies, definitely downies, non-invasive using pulse ox, overall systemic examination, and we need to continue with the holistic management as we talked earlier. I think I did mention that not mandatory for diagnosis of RDS or for deciding the need for surfactant. There you are going by the severity of distress. Of course, it would be helpful in secondary deterioration, if any, if that occurs. So the key messages would be respiratory distress, one of the most common causes of NICU admission. We need to identify the underlying cause as to why the baby has distress, because you saw that it can happen because of a lot of pulmonary causes, which are medical, pulmonary causes, which could be surgical, and non-pulmonary causes. So we need to monitor while the baby is on oxygen therapy, we need to monitor oxygen therapy. You have seen that there can be a myriad of problems with high oxygen being given to the baby. So this should be taken like a drug that is being used, and escalate to CPAP in babies that, wherever it is indicated, and you need to ensure proper monitoring. So term babies can be provided CPAP if they are not maintaining on the oxygen by prongs that we just saw. So they can be escalated to CPAP, but we need to ensure proper monitoring. We don't want to have air leaks happening there with CPAP. So I think that's all that I had to talk about in terms of respiratory distress in a preterm or term baby. Yeah, thank you. And I'll be happy to take questions. Of course, we have Dr. Saluja who's looking at the questions.
Yeah, thank you, Sushma, for a wonderful talk and taking us through the journey of management of RDS in neonates. And you have covered all the aspects of diagnosis and management. And I'm sure all the participants would have enjoyed your talk, and it will help them optimize management of a neonate with RDS. There have been few questions which I've tried to answer them to best of my ability, but there are certain issues which I couldn't handle, so I'll put those questions to you. Let's start from risk factors during pregnancy to do a septic screen and start them on antibiotics. And that was one question. You enumerated the risk factors. A word about spontaneous onset of premature labor. Is that a risk factor good enough to draw a sepsis screen in babies who have neonates?
So, yeah, you're very right that the risk factors are varied, and many of the aspects are taken as risk factors. For example, if a baby is preterm, he's also, his weight is also taken into consideration. So, it's made into two risk factors. It's a preterm baby, 30-weeker, and is a 1200 grammer or whatever. So we need to see that the risk factors that I had shown, about 6 of them are the ones that are important. We can expand the list to anywhere, because then when you say if there are 2 or more risk factors, do a sepsis workup. So that's extrapolated that way. Of course, spontaneous onset of premature labor is something, the history of which is not very clear as to why the labor started. Was there a reason, or was this just spontaneous start of labor? But if the clinician is suspecting that this could be a risk factor, he needs to work up the baby for sepsis. The point is not just starting antibiotics because there is one single risk factor. Even spontaneous onset of preterm labor, just one single factor may not suffice for, going ahead and starting the treatment for suspecting it to be infection.
And that's well said. And even in presence of risk factors, the risk of early onset sepsis may not be very high. It may be to the tune of at the most 12 to 15%. And even if you were to start antibiotics after taking a sepsis screen, don't forget to stop them after 48 hours once your screen comes negative and your cultures are negative. And very often I see that blood cultures are not drawn. And I think blood culture in today's time is very important to rule out, because other sepsis screen parameters, especially during first 24 hours, may not be of great utility to us in deciding about the role. But yes, cultures should be drawn. You highlighted about role of early CPAP in the delivery room and graded use of oxygen. I think it's a good idea to invest in oxygen blenders and have CPAP devices in the labor room. And not only in the labor room, you do good work, you recruit the lungs, start them on CPAP. It's important to transport the neonates on CPAP. Very often we think that we have stabilized the neonate and we have started CPAP and the NICU is not very far off. And if we don't have availability of a CPAP device during transport, we'll pick up the baby, take him without any respiratory support and rush to the NICU. And those vital 10-15 minutes which you take to reinitiate CPAP in the NICU may be lost. And what good work you did of recruiting the lungs in the labor room would be lost during the transport. So I think that's an important message, and all of us should thrive towards developing a mechanism where transport CPAP can also be given.
Yeah, absolutely well said. Absolutely well said. Yeah, because as we leave the baby unsupported in terms of pressure, the more and more alveoli tend to collapse. And when you reach the unit, the baby's temperature is fallen from where it was in the labor room, and the baby's lungs are not so well recruited during that transport. So when you reach, the baby's distress and all is, it's much higher, graded much higher. And that's the point when people feel that we need to do something more aggressive for the baby rather than just start him on CPAP. So these are absolutely, very, very important points.
Then another question about Downey's score. I think we still have cyanosis as a parameter in Downey's score with either in room air or in 40% FiO2. I think it's time that we need to modify this. We rarely see cyanosis in neonates with RDS right now. We don't allow them to get cyanotic. And maybe cyanosis could be replaced with some saturation level rather than taking cyanosis per se. So your views on that?
Yeah. So I would urge people, excuse me, those who are doing neonatology, looking after a lot of preterm babies, as well as term babies with respiratory distress, to devise a score. We need to have what saturation would be commensurate with 0, with 1, with 2. 0, of course, we are clear that it should be fine. So I would really urge people to work on this. And there was this Canadian group which worked on something on this particular score, and they tried to add even gestation to it. So less than 34 weeks was added. I think there was something to do with the leaking per vaginum, or something to do. So they had
the
added 2
modified
more
Downey score
parameters.
would have the gestation included in the ultimate scoring system.
So
maybe for the time being, if a baby is maintaining target saturations in room air or less than 40% or more than 40%, that is how, in absence of any evidence available, we would use Downey score in our unit. So I don't know how other units are using it in absence of picking up cyanosis. So that was one. There was a question on, can we rely on temperature being given by the warmer? Displayed temperature, is it accurate? Yes, I answered that question. Yes, if your equipment is working well and it has been calibrated, it should be, and the probe has been properly placed and fixed, you should rely on the temperature being displayed on the warmer. And it may be a good idea to take both central as well as a peripheral temperature, because that may also add on to the information. So you may have one probe on the chest or upper abdomen and one probe into the peripheries, and you could monitor central peripheral temperature difference as well. Then there was a question.
Also, Saluja, just a minute. Also, the digital thermometers that we have today, we don't have any more mercury thermometers. So when the nurse is monitoring, it just shows LO. If it is low, it just shows LO. So you have no other means to really know how low it is. It's these thermistor probes which serve you well.
Absolutely.
Provided, as Dr. Saluja said, it's applied well, and your machine is reliable. Yeah.
Maybe in times to come, we will have better digital thermometers which can be low reading, and rather than saying LO, it will give us the exact temperature, because that's how we would classify them into moderate and severe hypothermia, even through the auxiliary digital thermometers. Then I think the role of oxygen hood in the NICU. If I look at my unit for last 25 years, we have abandoned oxygen hoods because when you give oxygen by hood, especially during the acute phase of the illness, you're not giving any PEEP or CPAP. And the purpose is to recruit the lungs by giving end-expiratory pressures and try to minimize the exposure to oxygen rather than giving oxygen per se.
Yeah.
So I think we should discourage the use of or abandon the use of oxygen hoods unless you're in a place where CPAP may not be available. But I'm sure the participants who are in this group, most of us or majority of us would have access to CPAP. So that message is don't leave these neonates on oxy hoods because we have seen that they may maintain saturations for some time when you give oxygen through hoods. But then gradually as the atelectasis goes on and the child deteriorates and we unduly delay their further management and surfactant delivery and if we keep them on oxy hood. Similarly, I think you talked about...
Yeah, so I would completely agree with you that most of us have done away with oxygen hood. The only reason why it still exists in literature or in some of the modules is because wherever none of this is available, they could use oxygen hood. But as Dr. Suruja rightly said, the group that we have here probably have better means to provide oxygenation, and in preterm we definitely need to recruit the lung. So oxygen hood has absolutely no role. In term babies who are tachypnic, wherever you don't have oxygen prongs and other things, it may be used, especially at district level and below.
And we also must remember the early management of RDS during the acute phase. The main aim is to provide them PEEP, descending pressures rather than giving oxygen. And even the low flow oxygen, which we talk about, is during the weaning phase, during the recovery phase, rather than during the acute phase. So we should refrain from using, we know oxygen is toxic. Any amount of oxygen is toxic. I'll be very happy giving them CPAP or high flow in 21% oxygen
21%,
and giving any amount of oxygen. So I think that message has to be very clear with the participants. They try to provide them with PEEP rather than giving them undue oxygen.
And you would be surprised. I mean, most of us who've been working with small babies for a considerable duration now, many babies just maintain on something which is below 30%, and we have, reduced the use, or the use of surfactant has reduced so significantly because babies managed on CPAP from the labor room during the transport and into the unit, they are well managed at 25%, 28% oxygen with a pressure of 6, and they don't require surfactant. Surfactant people come and start speaking to you, what happened, why it is reduced.
Why
so
your usage has gone down.
management is better.
Quite right. I think the message is clear. Give PEEP, and that will help in majority of cases, and you can do without invasive ventilation and surfactant delivery. Also, it's important that don't unduly delay surfactant delivery. Try to identify neonates, and Dr. SUSHMA has very clearly said that any oxygen requirement in a setting of RDS with more than 30% FiO2 requirement, give early surfactant because evidence now suggests that delayed surfactant may result in a relatively poorer response. So try to give it within first couple of hours. But Dr. SUSHMA, the major issue comes in relatively bigger babies like 32, 33 weekers, 1300 grammars, 1500 grammars, who have enough strength to last the first couple of hours. And they are able to maintain saturations on relatively lower FiO2s. And as they tend to get exhausted beyond first 2, 3, 4, 6 hours, they get tired. They either start having apneas or they start having more retractions. And we often feel that we delayed the surfactant delivery. So my question is that, is it that we should account for work of breathing in addition to FiO2?
So I think that's what the CPG guidelines have looked at, and it is at a pressure of 6.
Yeah.
It's not at a pressure of, something like 4 or 5. At a pressure of 6, if you are requiring FiO2, which is 30 or more. And also we would look at, is this baby born by cesarean section? Is it one of the, multiple births? Is this baby required resuscitation at the time of birth? And so on. So you would,
and if antenatal steroids have not been given.
Coverage. So if all of them are towards, no side, maybe a relatively bigger baby also may qualify for CPAP. But to give it objectivity, it is like minimal retractions on a CPAP pressure of 6 and an FiO2 which is required, whose requirement is less than.
And I would like to add one more thing. Now that we are heading towards a new technology helping us in as lung ultrasounds and RDS, and there is some initial data coming in that lung scores may be higher in neonates who have moderate to severe RDS. And in these kind of situations, maybe lung ultrasound scores can assist us in giving early surfactants, but future will tell us how useful that modality is.
Yes.
So that can be considered. So there was a couple of more questions on feeding. So how early to give feed? That's number one. So you have said as soon as possible after birth, once you have initially stabilized, if the baby requires immediate surfactant, you have given surfactant, and then after you have done all that, you should give the feed. The question was that mom's milk is not available. So I had answered that question in the question and answer section, that try to counsel the moms before delivery so that she starts expressing as soon as possible after birth and tries to give you some bit of milk. Even if you are not able to start 60, 80 ml per kilo per day food feed, you should try to give whatever little EBM you get. And those units like yours who are lucky enough to have a donor's human milk, try to use.
So okay, I think you've answered that very, very well, because you are also somebody who believes in feeding babies quite aggressively from the beginning. So my answer to all those who are worried about feeding the baby is that when the first and foremost thing is you would settle your baby by 2 hours. If you have to give surfactant, your decision should come by 2 hours. That's what was seen in the trial. When we say ensure, early ensure is like by 2 hours of life. So try and make a decision. If you have a delivery which has occurred in your own setup, the baby is shifted to you by, let's say, 25-30 minutes. He's reached the unit. He is on CPAP. You have enough time to optimize CPAP and see if the baby requires surfactant by then or not. So 2 hours is the kind of outer limit by which we should have decided and given. So you have settled your baby, you've given him surfactant if he required, and thereafter the baby is being monitored. So now is the time to think of nutrition beyond 2 hours, around 2 hours, at 2 hours. So that would be the first feed. That's what we do in our unit, because we don't want the babies to land up with hypoglycemia. So by 2 hours, 2 hours of age, he must receive his first feed. Now coming to mother's own milk available or not, of course, I understand that all of us are trying to motivate the mothers to express milk. There may be nothing available by 2 hours of age. That's absolutely, the truth, prevailing truth. But then when we did the first trial, which is a randomized trial on early total enteral feeding with 80 mils per kg vis-a-vis 20 mils per kg, the MEN that we use, at that time we had no milk bank, please. It was preterm formula that was used. Preterm formula is meant for preterm babies' nutrition. It's not something which cannot be given, should not be given. Start with formula. You have given the first feed, you have given the second feed, maybe you've even given the third feed, 2 hours, 4 hours, 6 hours. But by then the mother is in a position to express or pump and send something to the unit. So something comes in by 6 hours, 8 hours, 10 hours. And thereafter, of course, you've already spoken to her during the antenatal period. There is somebody who's speaking to her now. So by the completion of 24 hours, at least about some 15%, 20% of the total amount is mother's own milk. That's good enough to protect the gut. You don't, there's nothing wrong that's happening over there if you're using preterm formula. So this concept of keeping NPO if I don't have mother's milk is something that I don't buy. And
thank you. Thank you, Dr. Sushma. I think you made my job easy. I was in a dilemma to mention formula coming from President NNF that you can use premature preterm formula. Yeah, absolutely. I agree with you. We do the same thing in our unit, but many of us are rabid about not mentioning the use of formula in neonates. I think as far as nutrition is concerned, we should think about, and then you should weigh the risk of sepsis in babies who are put on intravenous fluids compared to giving them enteral nutrition, preferably with human milk. If not available, yes, preterm formula should be an option. That's I fully agree with you.
I just want to add one more thing.
Yeah.
In our own unit, as well as, it's not donor milk available to all and sundry in the unit. It is only for babies less than 32 weeks who are receiving, and that too in the first 2 weeks. It's not every baby. So a 33 weeker, 32 plus, whatever weeker is not receiving donor milk, even if it is available in liters in the milk bag. So it's not for all babies.
And I can tell you, intravenous fluids is a major risk factor
Risk
for nosocomial sepsis. And we are living in a country where all said and done, our aseptic precautions may not be perfect. And any child who is on intravenous fluids is a significant risk factor for sepsis.
We
So
burnt our fingers with that.
absolutely.
All of us
So
have burnt our fingers with that.
So there is no harm in saying, yes, human milk is the best. If available, should be used, whether mom's own milk or donor's milk. But short of that, rather than giving them intravenous fluids, put them on preterm formulas. So that will close that question there only. Yes, if a child is not fit enough to be given enteral feeds for hemodynamic instability or other reasons, if you start them on IV fluids, give them parenteral nutrition. Just don't leave them on
10%
dextrose.
dextrose.
Because, yeah, so it's a good idea to give them not only amino acids, but also lipids. The dose can be decided on day 1, day 2, day 3, because if you give amino acids without any calories and lipids, then you're wasting those proteins as well. Unless you give them reasonable calories, the proteins are not going to be utilized for nitrogen utilization. So we'll end that question.
If
Yeah.
the chair permits, just one last word.
Yeah.
Mother's own milk is the best. Donor milk is just above preterm formula. It's not the best. So these two are not equated. Mom and donor milk are not equal. Mom is here, donor milk is here, and preterm formula is just below that.
But you must remember, donor milk has human attached to that. So that's still a human milk rather than a formula. Fair enough. I think we'll leave it there. Sure. Then we came to, there was another question about second dose of surfactant. We said we give them surfactant, we insure them, put them on CPAP, and then we gradually increase their CPAP by 1, going up to 8 or 9 or whatever level you want to use, and go up to NFI2 of 0.7. So how long would you wait for this neonate before you think of giving? How early can you give the second dose?
So Dr. Saluja, very clearly, very truly speaking, there is no objective parameter, but most people who would assess the baby, iska charger la de zara. Who would assess the baby, it would be a time which is beyond 4 to 6 hours. It isn't right, just maybe 2 hours later or something. You still need to optimize your settings. So probably.
Sure, I think by 4 to 6 hours is, or if you were to intubate early, you can, in a severe disease, you can consider early, but 4 to 6 hours should be a reasonable time. Another question was, how late can you give surfactant after birth? Is it, till what time can you consider giving them surfactant?
So as the CPG group on surfactant for NNF, I was chairing that group and we deliberated a lot and we actually looked at literature. So there is no literature on, there's hardly any literature on giving it late. But I think we have addressed that question by saying if the baby comes to you late, maximum by up to 48 hours. But that was, there's no evidence to it. There's hardly.
Sure enough. I think we, like in our unit, we are an extramural unit. We do get babies of RDS who have been managed with HOD or CPAP, and they're transported beyond 24, 36 hours. And we end up giving them surfactant even at 36, 48 hours. And get a variable result. It's not uniformly that good a result as when it is given early enough in first 6 hours or so. But yes, it can be considered at that point of time. Then there was also a question on if there is no meconium, there are no risk factors for congenital pneumonia, but you do make a diagnosis of pneumonia. I think you addressed that question, that severe pneumonia with an OI of more than 15, they can be considered. Yes, people have used even later on, because surfactant gets consumed and secondary surfactant deficiency can be there. People have even tried using it in pulmonary hemorrhage. So that can be decided on a case-to-case basis rather than making a generalized recommendation. Then finally, I think there has been talk about, you talked about nasal injury. And I think more and more of us are now moving towards HHFNC. And we recently did a research project on a DNB student, and we found that even for primary respiratory distress, 50% of them did respond to HHFNC. and we didn't have to grade up to CPAP or invasive ventilation. So I think all of us now, that causes less.
What gestation?
They were between 30 to 34. They were not below 30 weeks. And most of us, or many of us would treat babies about 28 weeks. And so, but yes, in relatively bigger babies, we can consider that, or we should try to minimize the period of nasal CPAP when it is likely. But it's a good idea to not only look at the nose regularly, but nurses can maintain a score. There are a couple of nasal injury scores available. So as a part of their monitoring sheet, they can also have built in the nasal injury score, and the nurse could do it every hour, every couple of hours, objectively looking at it rather than looking at every now and then. So there are no more questions which I have. And if other
I see there's a question saying, do we need a ventilator if we are giving surfactant? Clearly, no. You could give surfactant on CPAP. And CPAP without blender is ideal? Of course not. CPAP with a blender is ideal. I'm not sure if that was a typo or the question actually means that.
So now I can see a few more questions here. Where should we replace HFNC in the management? I think we addressed that. For TTN in term neonates, there's a question for TTN in term neonates. I don't know what exactly they're trying to ask.
We can use CPAP for TTN in term neonates. We could use, as Dr. Saluja just said, it could be just by nasal prongs, you are giving oxygen, or you are giving, if you have high flow nasal cannula, you could use that. And you could even use CPAP. I think the question relates to, there is a fear of using CPAP in term babies. So yes, you can use CPAP in term babies as well. And we all do use, even in babies who are coming through meconium, if the distress is not very high.
I would rather say you should use rather than you can use, why not? It will help in early absorption of the lung fluid, which probably contributes to TTNB as well. Outborn baby with HMD and pneumothorax at admission, should we give CPAP trial and ventilate immediately or ventilate immediately? That's a question.
Sorry, I was scrolling.
Outborn baby with HMD and pneumothorax at admission, should we give CPAP trial or ventilate immediately?
It will depend on how severe is the respiratory distress that you are assessing. If you have put in if the pneumothorax is being drained, you could still go ahead with CPAP, not an issue. But if the distress is high, you are not very comfortable with that, sure, go ahead, intubate the baby. It isn't that it's completely prohibitive that you don't ventilate babies.
How to decide for surfactant in severe MAS babies? I think you addressed that in your talk. And a severe RDS who has been intubated and has an OI of more than 15, that should be fine. A question on indigenous CPAP.
I think we are now having CPAP even at district places. So where is the situation? Where is the place for indigenous CPAP? If you don't have anything, you will support the baby with whatever you can. But I think we should invest in buying CPAP machines rather than invest in buying many other things, including a ventilator. I mean, if you have one ventilator in the unit, you should have at least 4 CPAP.
Absolutely, absolutely. And ventilator works more like a backup rather than as a primary mode of treatment. We should be giving a trial of non-invasive first, which is CPAP, and then in failures, consider that. Role of caffeine and duration to provide in recurrent apneas and early BPD. I think you addressed that.
Yeah, it's there.
Want to say something more on this?
No, I think we are very clear on, if there is an apnea that has occurred in a baby, preterm baby, you have started caffeine, it needs to go on till the baby is apnea free for 7 days and gestation of 34 weeks is crossed. So in fact, we are working on this, Dr. Saluja, to see if we can stop caffeine earlier in babies who are apnea free for 7 days. Because once you are treating babies who are 26, 27 weekers, going on giving caffeine till that long, maybe there is a window where we can stop around 32 weeks. So currently we are doing a research on that. Let's see what the results are.
Some of us also feel caffeine as a bronchodilator in babies with BPD. I don't know. We need to have data on that, whether it helps in that situation or not. Then there is a question that I think ensure also needs to be clarified. What does ensure mean? That you give surfactant and come out? Or you look at certain criteria before you extubate them? In other words, what are the factors which predict failure of insure?
So yeah, once you've decided to give surfactant, you intubate the baby, you give surfactant in aliquots, up to 4 aliquots, and in between you are ensuring that your saturations are fine. It's not just one after the other. If you can connect back to the device on which the baby was before giving surfactant, connect, or at least you would do bag the baby. So after the surfactant has been given, you're going to see whether he's maintaining his saturation or not. Because at this juncture, we may defer Dr. Saluja in what we are saying and what I'm going to say now, that if the baby is maintaining his saturations, it would be good that you come out and this baby is managed on CPAP. But if, because most often when the baby remains intubated and connected to the ventilator, there is a tendency to just prolong it up to 6 hours. Okay, let's have overnight, let the baby be on this. Tomorrow morning we'll extubate. So this is what is my take on it. If the baby is maintaining saturation, get the tube out, optimize the baby on CPAP. You have enough range for CPAP to be optimized on from 5 to 6 to 7 to 8 pressures, and so also the FiO2 that we.
You see, when initially insure was described, it was take it out immediately after giving surfactant and put them on non-invasive ventilation and then look for insure failures. But there, I was looking at a paper published a couple of years back, which looked at predictors of failure on insure, and they found a gestation less than 29 weeks. And those neonates who have higher FiO2 requirements more than 40%, and those babies who had higher lactates more than 2.8 millimoles. So these could be considered, but I think we'll have to generate data in our own settings. But yes, ideally insured should be immediate, but then we should try to identify factors which will result in higher failure of insure and try to address them so as to minimize failures and then reintubations. I think we don't have any more issues to discuss. I'll thank you very much, Sushma. It was lovely interacting with you, and we had a great discussion. And I would hand over to the organizers to take it forward.
So likewise, Dr. Saluja, you were there, so I was like, okay, relaxed.
Thank you so much, Dr. SUSHMA, Dr. Saluja, and IAP Delhi for giving us this platform to discuss this topic, which is the most important topic when the baby enters the NICU. But I am sure this will interest all, must have helped the queries of all offices, pediatricians who do some bit of neonatology. As you can see, Dr. SUSHMA, we did our talk 50 minutes and we're already 40 minutes discussing questions. So they are very, very important, simple, but relevant questions to their practice which they ask. So we have few minutes, so I can take this liberty to also thank Dr. Jaleel Ahmed, who's just left the panel, and Dr. Nomita Gupta has joined us. She's also a very important senior member of IAP Delhi, and Dr. Lalan Bharti, who's still there on the platform. Definitely, this type of course will help all the pediatricians in updating their knowledge. And as we get the scope, we may be doing even an extensive or more core neonatology course in future. I'm sure at Shine, Dr. SUSHMA is doing great work, and for the PG students when they are discussing the real neonatology of indoor NICU. But our objective is to upgrade knowledge of all office-based pediatricians. So with these words, I'll thank you all again, and I
Dr.
request
Pankaj,
all the delegates.
Dr. Pankaj, give me a second. This Shine will be launched on 12th of August. That is coming Monday, not tomorrow, the next Monday, for the DNB students. So it has been done for the MD postgraduate first years. Now we are opening it for the DNB students. So all those who are here and running DNB institutions, I've done 2 Zoom meetings, but they may or may not have joined. So I will take this opportunity here to inform that on the 12th we are launching. So before that, the students need to register. All the details are there on the website. Thank you so much for this opportunity, Pankaj.
Right. And this session has already been recorded by IAP Delhi, and it will be available to link 24 hours from now. So those of you who missed some part of it or you want to revise it, again can listen to all. And I will request all the delegates to listen to all the 14 sessions, because once the 15th session is over, a week from that, we will be conducting an MCQ-based test, which you need to clear before we issue a certificate on this course. with these words, thank you again. Thank you, everybody. Have a nice Sunday. If you did your academic work well, now enjoy the day.